This is TAVR, Leriche, Lovin. Disclosures. So let's get to the case. It's a 73-year-old white female, very high-risk patient, multiple comorbidities, multi-level vascular path, both coronary and vascular. She had an RCA, CTO, PCI in the past. She had a left circ PCI. She has a porcelain aorta, subclavian and carotid stenosis, bilateral SFA CTOs, and Leriche syndrome. That's what we're starting with. Low body weight, high frailty with severe ES, a valve error 0.7. So she was referred to our TAVR clinic. We're looking at her and we're like, oh boy. So she had 2 admissions for heart failure. Her STS score, I think, was 8 or 9%, and this is what we were up against. So we brought her in to do an elective angio. Unfortunately, I don't have the CT scan. Couldn't get the images uploaded, but this is what we're dealing with here. Basically, her aorta is occluded from the inferior mesenteric artery, up here on the top of the screen. On the right, down to the distal common iliac. On the left, the entire external in the left common femoral artery with reconstitution at the level of the mid CFA on the left with their hypogastric collaterals and lumbar collaterals. So she did have chronic flow down the leg. Here's an angio here if it plays. So again, took this angio. I'm like, oh boy, how are we gonna get this valve in this lady? So we stopped, took her off the table, and then went back to our structural heart team and said, guys, this clearly is an alternative access case. What do we do? So transax, which is our second default if it's non-transfemoral, we do transax cases. They're only 3 millimeters, so obviously that was out on both sides. Transcable, we've done a transcable. This was obviously not the case for a transcable, especially if you've done only a few. There was severe calcium at the puncture site. Obviously the aorta is occluded. There's no bailout access. We can't do an endograft coverage stent. Direct aorta, again, we're dealing with a porcelain aorta, so that was out. A transanominate, severe calcium at the arch, severe calcium throughout the entire aorta with the porcelain aorta. So that was off the table. Possible transcarotid, her duplex showed she had disease in both the common and internal carotid, so that was off the table. Transapical, it's possible. She's very thin and frail. Our CT surgeons actually deferred and turned her down for a transapical. We've done 1 TA case in about 4 years, and that one ended up with an LV pseudoaneurysm. So we went back to the table and said, guys, what do we do? Along comes our shockwave rep. He's like, hey, let's give it a shot. So what I actually did was wanted to phone a friend here. My former senior medical resident was Dr. Tayal there at the end of the table. So what do we do? We went back and used our coronary CTO wire skills. Used a Confianza Pro 12, a Pilot 50 coronary wire, and a Corsair 135. Was able to wire through, confirm we were true lumen using the Corsair, took a puff through the Corsair, we were up in the mid aorta. Used a 4 millimeter non-compliant balloon to facilitate the IVL catheter, so did a few inflations with the 4ONC. Was able to track up the catheter and did 7x60 IVL catheter with 240 pulses at 4 atmospheres. It ended up using a bailout 9 millimeter OmniLink bare metal stent just to tack up that mobile chunk of calcium on the right screen there. So we didn't do the TAVR in that setting. We actually kept her overnight, washed her. Again, this was my first shockwave case, so I'm like, not sure what to expect. Sent her home the next day and actually brought her back the following week, and this is her baseline angio pre-TAVR. We were quite happy with that. This is the baseline a week before.
Amazing.
So then what do we do? Our 23 millimeter S3 deployed it via rate transfemoral, had no PVL, had no conduction disturbances. That was our final outcome. So case follow-up, the patient did exceptionally well, was discharged home post-op day 1. We're gonna plan to bring her back and shockwave her right iliac and either do kissing stents to recreate the bifurcation or possible endograft. So key takeaways from this case is that an occluded aorta is no longer prohibitive for transfemoral TAVR. Mm-hmm. Final thought, in my perspective, alternative access may have met its match when it comes with the advent of aorta iliac IVL. Thank you.